Dr. Johnson for that excellent talk. It's fantastic. Now, we will invite Dr. Grothey. Where's Dr. Grothey? Oh, there you go. We'll invite Dr. Grothey up to moderate the GI session, panel discussion and Q&A. We'll invite back up Dr. Lenz, Dr. Paxton Dickson from UT Health Science Center, Surgical Oncology, and Noam Vanderwalde from West Radiation. Dr. Noam Vanderwalde, I'm so sorry. But
Hi. I'm a radiation oncologist.
You're from radiation? So great to have you here. You know, as Heinz said, colon is the most important organ, but I clearly get your point. You know, I'm kind of partial to pancreas cancer. We have a multidisciplinary team here, you know, and we'll have a tumor board. We have 2 cases, and we will try to really have a nice discussion. The first case is a case that I actually share with Dr. Dickson, and which kind of highlights a new paradigm, I think, how we should treat patients with MSI-high gastric cancer. So this is a patient, a 59-year-old female patient, had an ulcerated lung bleeding malignant appearing mass in the antrum when she was worked up for anemia. Biopsies confirmed a mildly differentiated adenocarcinoma, a loss of MLH1 and PMS2 per immunohistochemistry. I think this is standard workup right now that we should do. Every patient with an adenocarcinoma in the GI tract needs immunohistochemistry, because it's really important, because we don't want to miss patients who can really benefit from immunotherapy. So then she came to us, and you know, we further worked up her, including genetic testing, you know, because you have an MSI-high tumor here. You know, we did a KRAS testing, so tissue testing. And this tumor was actually interesting because it was not only TMB high, MSI high, but also Claudin positive. I'll show you the result in a minute. And then we had a PET scan with hypermetabolism. You know, we always work patients up with gastroesophageal cancers with PET scans for treatment planning, particularly in early stage disease. And she actually had, interestingly, lymphadenopathy, mediastinum, upper abdomen, and she had actually pre-existing sarcoidosis. You know, something interesting, because interestingly, on treatment, her pulmonary lesions and mediastinal nodes actually grew. Okay, so here's the KRAS report. You can see molecular profiling, mismatch repair deficient, TMB high, Claudin positive. We have been testing for Claudin positivity for quite some time. HER2 negative, PD-L1, CPS score of 2. A question, of course, what do you do with that? So, question is, how should we treat this patient? Dr. Johnson.
Yeah, so this
you know the slides, right?
Yeah. This is an interesting question. I think that what we know is that in patients who have loss of mismatch repair protein, we know that those patients do not benefit from chemotherapy the way that other patients do. And we know, on the other hand, that they respond beautifully to immunotherapy. And so I think if you look at the NCCN guidelines, for example, around these patients, I think it's still relatively carefully phrased. I think it says something like may consider immunotherapy. Yeah. But given there have actually been some trials that have even indicated that chemotherapy may have bad effects in these patients. I think that given that, and given the fact that immunotherapy works so beautifully, you would be, unless you had a specific reason not to want to do it, you would be hard-pressed to come up with a reason not to at least think about offering immunotherapy here.
Yeah. So, I mean, that's what we did. And, you know, it's interesting because this report, he does not give you the nivo-ipi option, but we did nivo-ipi because I believe, you know, and I think Heinz pointed this out, this is probably the best tolerated and most effective immune therapy that we have right now available as commercial available.
Yeah, and it's interesting, the TMB is 30, so there are some data, at least in colon cancer. So a TMB of 30 and higher, particularly does well with the nivo-ipi combination. There is also a cutoff. Yeah. If the TMB is not high enough, the efficacy is going down. So, and there are some data nivo-ipi in gastric.
So we followed this patient, and you know, as I said, you know, they are the non-metabolic pulmonary nodes were actually enlarging, and we thought, you know, and the mediastinal nodes were also enlarging. So probably sarcoidosis related. There's actually data on that you can stimulate autoimmune or granulomatous disease with immunotherapy. So we checked with endoscopy, and the initially ulcerated appearing mass had shrunk. I don't have the path slides, unfortunately, right now, and there were really only now dysplasia and features worrisome for malignancy. And then eventually, we had discussion, is that definitive treatment, or should we actually do surgery? And this is where Dr. Dickson comes in, and because we talked about what the extent of the surgery should be. And, Paxton, what did you eventually do?
Well, as you mentioned, this was a case that we discussed and had followed her EGD, and although she'd had a nice response on EGD, I don't think we're at a point where we have complete comfort in just monitoring these patients. It'd be difficult to follow with comfort that you had unequivocally caused a complete response, even with repeated EGDs and biopsies. So we went ahead and performed a distal gastrectomy with D2 lymphadenectomy, which would be our standard in any patient with gastric cancer like this.
So that's what happened in December. So she had a distal gastrectomy, and interestingly, pathology confirmed a complete response. There was no tumor material anymore. We saw these lymph nodes with granulomatous lymphadenitis. Stains were negative, and here's the final pathology, really, and we looked through that actually in our tumor board. There was no cancer left, so it was kind of potentially cured with immunotherapy, but of course, verified, which I believe is still standard of care, with a distal gastrectomy. But there are ongoing trials where patients get randomized with clinical complete response to surgery versus just observation. Yeah.
I'll just make one comment, which is just because we're learning about how to manage these patients currently. When we opened her specimen up, literally after taking it out, back table, make sure our margins, you could see just a faint hint of where something had been. So, 6 weeks prior, she had an EGD, still with an ulcer, with dysplasia, but by the time we actually did her operation, grossly, there was hardly anything there. And so I think that we will move to a day where there's a select group of patients that can be safely observed. Certainly not there yet, but it's very important for all of our education.
Yeah, it might also be different whether you have a 59-year-old female or a 75, 80. Yeah, Heinz.
So, and I completely agree. We are not at the point for watch and wait. It's much easier in rectal, or for the EGD, it's not much more difficult. And there is actually a lack of a reliable liquid biopsy for gastric cancer. It really suffers from the sensitivity in a way. If this can be addressed, it may be much easier to better select these patients. I completely agree that there is a watch and wait possibility, but at the moment we don't know for sure who these patients will be.
Yeah. So I actually saw her this week, and she had a kind of surveillance starting, CT scan, no evidence of malignancy, and we still saw these lymph nodes. Okay. Next case. So this is a case which now Dr. Vanderwalde and I share, and two other colleagues who are not here, liver surgeon and colorectal surgeon. So 41-year-old female patient who was pregnant with her fourth pregnancy and had abdominal discomfort. And when you're pregnant, it was like, this is probably related to pregnancy. And she delivered her fourth child, persistent discomfort, and was too busy with the 4 children to really get worked up. Had blood per rectum, always deferred it. Half a year later, had a colonoscopy, and then had a mass, a pretty large mass, 5 centimeter mass, mid to high rectum, partially obstructing, biopsies confirm moderate differentiated adenocarcinoma. And then, we worked her up, etc. There was no evidence of distal metastasis. She had an hemangioma in her right liver lobe, and then MRI, of course. This is the MRI here. You can see pretty large mass and see perirectal lymph nodes. Now, Noam, what's our standard here?
So yeah, we again, young patient. We would normally try to do a TNT approach on this patient. She was interested in non-operative management, and we currently have a trial open for these patients, the Janus trial, that randomizes everybody starts with chemoradiation, and then they get randomized to either a standard FOLFOX or FOLFOXIRI or FOLFIRINOX.
Whatever it is.
Whatever you want to call it.
Yeah.
But a 2-drug regimen versus a 3-drug regimen. But I'm sure as you're going to present, she unfortunately
Yeah,
is
yeah.
not eligible for the Janus trial
Yeah.
because of other medical comorbidities.
Now, I think this slide here shows you when we start seeing a patient with rectal cancer nowadays, and we can talk about stage, when are we employing all this, we really like to enroll patients in this Janus study, which tries to shoot for non-operative management. And the time when we start treatment until we have a decision whether or not patients go to surgery is 9 months. So that is it's a very different paradigm to, let's say, when I grew up in oncology, rectal cancer, rectal surgery. This is very, very different. We do a lot more upfront. Now, this patient had issues in many ways. So first of all, her ctDNA, we do routine ctDNA testing in early stage colorectal cancer. She had a positive ctDNA before we started therapy, which is good because we can follow her. And then she had an elevated indirect bilirubin, and I did a UGT21 analysis, and she was homozygous for UGT21 star 28, which is Gilbert syndrome, meaning she has poor tolerability of irinotecan because she cannot metabolize it. And that made her not a candidate for the Janus study because, as Noam said, this is randomization to a irinotecan-based regimen or just FOLFOX. Okay. So we started her on radiochemotherapy with capecitabine, like what we do. And then she developed severe coronary angiospasms. Went to the ER, had no permanent cardiac ischemia, but this happens. And Dr. Johnson, what was your take? Do you see it in clinical practice?
Yeah, we definitely do. It's unusual, but I see a handful of patients every year who have what, after a careful workup, appears to be 5-FU-induced coronary artery vasospasm. And it can be really challenging, right? Because for a young person with colon cancer, or rectal cancer, whether you're treating them in the metastatic setting or the perioperative setting, 5-FU is the basis of virtually all of our chemotherapy, and even more so in this poor patient who also has Gilbert's, right? There is some anecdotal experience that if you absolutely must, so two things are true. One is that sometimes it can be different between Xeloda and infusional 5-FU. That's an important thing to know. And then the other thing is that there are, if you really, really need it, at least at Stanford, we now have a cohort of our cardiologists who are cardio-oncologists, and sometimes we will try to give vasodilatory agents like amlodipine or nitrates if we, as a sort of secondary prophylaxis, if we have to keep using the agent that caused the vasospasm, but the efficacy of those is not perfectly reliable. So it's a challenging situation. I would recommend working in combination with cardiologists.
Yeah, so
I will say, as a radiation oncologist, this was a very important life lesson to me of don't ignore a 42-year-old complaining of chest pain, even when you're radiating the pelvis.
And it's independent of coronary sclerosis. Young patients can have coronary spasms, actually. So this patient became more complicated because, actually she had an imaging response after radiation therapy, more or less, but her Signatera level, the ctDNA level, actually went up. And, then she entered the second phase of chemotherapy. So there are actually data, as Dr. Johnson said, bolus 5-FU, for instance, doesn't induce spasms as much as continuous administration of fluoropyrimidine, and that's well documented. So we tried her on Flox. It was bolus 5-FU leucovorin oxaliplatin. Remember, that was initially one of those things that were tested when oxaliplatin came about, but it's associated with a very high degree of severe colitis. And she had a grade 4 colitis, right in the first week after starting with Flox. And so she can't get oxaliplatin with bolus 5-FU. She can't get continuous infusion of 5-FU, no capecitabine, and she has problems with irinotecan. And that's a young patient you still want to cure. Okay. And then we, of course, part of our routine workup at that point, also to follow up with the higher ctDNA level, showed a liver lesion. All of a sudden she had a liver lesion in segment 4A, and she still had a primary tumor in place. And this is here, her liver lesion. Looks pretty resectable, I guess, Paxton? Yeah. And for us, this was the idea, this could explain the higher ctDNA level. So we had a long discussion. This patient did not really get adequate radiochemotherapy, did not get chemotherapy, very limited treatment options. So then we have to really, if you really run out of options as medical oncologists, you have to call the surgeon. Okay, so actually she did go on a lower anterior resection, partial liver resection, and 4A and 8, microwave ablation, cholecystectomy, and we had all these, final tumor stage was T3, N1A, M1A, and we thought it was done. But the story goes further. She did get a scan after surgery, And there was no evidence of active disease, but the ctDNA was still positive. So he had not cleared after potentially curative surgery. And what do you do there? You cannot ignore this. You cannot ignore this, especially if you want to get this patient still on the curative track. So we did another PET MRI in September, and lo and behold, she had another liver metastasis and this recurrence at the site of an ablation, per PET and MRI criteria. So what do you do? Again, no treatment options that we have. So, and you see here, again, Paxton, you'd say, this is potentially resectable. There's a second resection within half a year. So she actually did go now to an open liver resection by a dedicated liver surgeon, and she had an ileostomy which revised, etc. So she did again have pathology confirmed adenocarcinoma, and I actually saw her with a scan at the end of January. Yeah, this is actually right before her liver surgery. You see how the ctDNA goes up. Liver metastases shed. They shed. So that's why you pick these up very well. Not necessarily lung lesions, peritoneal disease, mucus histology. We all know that. And then, this is her last scan. And the scan was very difficult to read. You can see it here on the right-hand side. There's a hematoma versus abscess. She had no infectious complication. There's this area around the liver between, diaphragm and liver could be postoperative infectious in nature, could be peritoneal disease. But I mean, she still has this hemangioma. What do you make out of that? And in the radiology report, she says correlation with ctDNA would be of value, which is interesting.
That's quite the radiologist, I just want to say.
Actually, he is quite the radiologist. He actually looks at patients' charts and ctDNA levels before he interprets scans. And that's her level. She's negative for the first time. It was quite emotional when we talked about her because she has followed this, of course, for the whole time. So hopefully this will translate into something long-lasting. Complicated case. I'll report next year, what happened with her. Okay. Any other comments, questions? Heinz, what do you think?
I mean, you cannot argue with success. But I think I would have probably used maybe a cetuximab, bevacizumab combination. Remember a long time ago. We published that in JCO. The combination first line failed, but in refractory, the response rate was 20%. So that would be something you could consider, but I cannot argue with a negative signal.
I mean, when patients have Gilbert syndrome, they can still get irinotecan, just need to be very careful. Yes. Very careful. So there's this tiny little opening that we have for her, if she really needs and when she needs treatment, I think. Yeah. So this is really an interdisciplinary approach, and again, you can't argue with success. Let's see how long-lasting the success is. Thank you, everyone. Thank you very much. And yeah. Okay.